So next, it is our absolute pleasure to introduce our opening keynote speaker, Dr. Rhea Boyd. I'll share a little bit about her before she begins her presentation. And I know she's here joining us virtually. Hello, Dr. Boyd. Dr. Rhea Boyd is a pediatrician, public health advocate, and scholar. She earned her MD at Vanderbilt University School of Medicine and completed a pediatric residency at UCSF. She graduated from the Commonwealth Fund Mongan Minority Health Policy Fellowship at Harvard University School of Public Health with an MPH. And she writes and teaches nationally with a scholarly focus on child and public health impacts of structural racism, inequity, and health. She partners with community-based and nonprofit organizations, public health departments, and academic centers to understand and address forms of social inequality that contribute to poor and inequitable health outcomes. She is the senior advisor on equity and justice for the California Children's Trust, an initiative to advance mental health access for children and youth across California. Now let's please give another warm welcome to our esteemed speaker, Dr. Boyd. Dr. Boyd, we're ready whenever you are.
Hey, y'all. Give me one sec. Okay, I think it's all set up. Gosh, I am so honestly honored and grateful to be with you guys. I know I'm virtual and I really wanted to be in the room today, but I live really far and I also have a daughter that I have to pick up, which I'm sure all the mamas and caregivers understand. So thank you so much for having me. I'm also honored to talk about this topic as a Black mother, as a Black birthing person. But I also want to say, before we even get started, honestly, just putting these slides together, and I just realized I put April 10th, which is the last time I practiced this presentation. Putting these slides together was emotional. And, you know, the process of having this conversation today may be emotional for some of us. And so if folks need to take a pause, if we need to take a beat or a second, please drop it in the chat or the Q&A, or the moderators can let me know. There's a lot to go over, so I'm going to jump in. And then I want to save like 15 minutes at the end so we can just have discussion amongst us, conversation, questions, all of that. Okay? So let's get into it. Today we're talking about the politics and policing of Black motherhood. Let me see if I can bring this thing at the top down. Hold on one sec. This thing is over like half my screen. Well, maybe it won't go down. Okay, that's okay. Okay, here we go. So first, I don't have any conflicts of interest. Nobody's paying me to say this today. Although, obviously, they are giving me an honorarium from speaking, which I'm grateful for. So I want to start by setting an intention together. So if you feel comfortable, close your eyes. If not, that's okay. For our visual learners, there's going to be little prompts on each page too. But let's set an intention for this time. I want to start by first saying this is not a talk about maternal mortality. This is about Black motherhood. It's about our responsibility as public health leaders, as gatekeepers of vital life-affirming services, as providers, clinicians, nurses, doulas, and just fellow neighbors and citizens. To see Black women, mothers, and birthing persons, to see our stories, our agency, and aspirations. To honor Black women, mothers, and birthing persons for who we are and for how we choose to receive our care. And to have reverence for what Black women, mothers, and birthing persons are attempting and enduring as we begin, or in many of our cases, continue loving and caring for Black children in a nation that was founded upon and continues to profit off of the collective subjugation of Black people and Black birthing persons in particular. This presentation is also about our responsibility to love Black women, Black mothers, and Black birthing persons, and to demonstrate our love through how we care for each other and for our attention during a time of Black women, birthing persons, and mothers' relative vulnerability. So I want everyone to set their intention now for how you're going to listen to this presentation. Are you listening as a public health leader, or perhaps with your hat on as a gatekeeper of these vital life-affirming services, or as a provider, or a neighbor, or a citizen? Perhaps you're listening as a Black birthing person yourself. And where do you specifically, personally, have room to grow? What do you need to learn to see Black women, mothers, and birthing persons, to honor us, to have reverence for the lives that we live, and to really love us and show us that love through your care in whatever role you occupy? So we're all going to take a deep breath together. Hold our intention tight, and let's get started. So what are Black birthing persons attempting and enduring when we care for Black children and Black families? This is a quote from an article I wrote in The Nation magazine last year, where I said, perhaps the most intrusive aim of the colluding systems of domination, that's patriarchy, white supremacy, and capitalism, is to render Black women in particular foreign to our own selves. Put another way, a particular mode of economic exploitation and racial degradation functions by making Black women unrecognizable to ourselves, so that ultimately our bodies can be made unavailable to us. What does it mean to have your body made unavailable to you? And how has this happened, and how is this happening to Black women, mothers, and birthing persons in our care? To understand that, we have to go back to the time of chattel slavery. Enslaved Black women's bodies were made unavailable to them to render them available for physical labor, forced reproduction, and scientific experimentation. The type of experimentation that OBGYN, or obstetrics and gynecology as a field, was built on. The image I have here is a picture of a poem by poet Bettina Judd, and she is reversing the story that is offered by J. Marion Sims. J. Marion Sims is known to some as the godfather of obstetrics and gynecology, and to others as a tormentor. And she begins the poem by using a quote from J. Marion Sims' own autobiography, in which he says, "Introducing the bent handle of the spoon, I saw everything as no man had ever seen before." And what Bettina Judd does is she said, actually, Betsy invented the speculum. This poem is on behalf of Betsy. She said, perhaps Betsy would say, I have bent in other ways to open the body, make space. More pliable than pewter, my skin may be less giving. Great discoveries are made on cushioned lessons and hard falls. Sims invents the speculum. I invent the wincing, the if you must of it, the looking away, the here of discovery. I include this because there are many ways in which we can talk about Black birthing persons and Black women's bodies, but we also have to acknowledge at the onset that the foundation of what we even know about reproductive health has happened on the bodies and the lives of Black women and birthing persons in a way in which they did not consent. That exists inside a larger predatory political economy. Some people describe the United States political economy as racial capitalism, right? So we're a capitalist economy where only a few people get to accumulate most of the resources. And living in Santa Clara County, we all know who those folks are. But we're also a country that has an enduring racial hierarchy where Black folks can sit at the bottom of that hierarchy and white folks can sit at the top. And that enduring racial hierarchy has become a very effective means to determine who can accumulate most of the resources. And so inside that predatory political economy that takes from folks at the bottom and gives to the few folks at the top, Black women can come to exist just to be used up by other people. Our bodies used just to fill other people's desires. Our talents employed just to meet other people's needs. And our time squandered just to satisfy other people's sense of urgency. Even the space we hold in our own minds for our own emotions can come to be filled up with other people's tears. This is again from the article I wrote in The Nation last year. So why does that happen? It's because the goal is domination and the type of profit hoarding that can only be created through racial and gender subordination. And so that domination is achieved through extraction of Black women, mothers, and birthing persons' bodies, and our production, our labor, and our reproduction, the product of our labor. That extraction continues today. Among adult women, Black women have the highest rates of workforce participation, and we disproportionately work in service industries like education and health services, yet we receive less compensation than our occupational peers. That means that more than 6 in 10 leaves needed by Black women are not taken or taken without pay. So not only do we work the most, we're least likely to take the breaks we need, or when we do take that break, we're least likely to be compensated for it. As a result, it's estimated that Black women lose $3.9 billion every year due to lost wages while on leave. That's $2.8 billion while on our own health leaves, $866 million while on parental leaves, $223 million while on caregiving leaves. These wage thefts, because we know we don't have a federal leave policy where we have guaranteed paid leaves, these wage thefts where Black women are not paid for the time that they need off for their own care or to care for others can have dramatic effects on household finances. It's because Black women and women of color in general are most likely to be breadwinners or the highest earner in their household. So if you look at Black women, we see that 68% are breadwinners, right? That's almost 7 out of every 10. And if you look at folks who are co-breadwinners, meaning they and their partner have the highest incomes or they match each other's incomes, that's 8 in 10 Black women lead in the income winning for their family. Speaking of women who are leaders, we're going to follow the story throughout this presentation of these 4 women. I wish I was in the room so I could see if folks already know who they are. But this is the United States 2016 Olympic champions who won the 4x100 relay. This is the team. And this is a quote I included here from Allison Felix. She's on my left, but maybe in the room for some of you guys on your right. She wrote an article in Time magazine about her own experience while she was pregnant. And she said she was 6 months pregnant and she was scared enough to train in the dark. An Olympic champion. Before the 2016 Olympics, Allison Felix had already won so many medals, more than we can count on a single hand. And she said she did that so that no one would see the life growing inside of her. So in addition to talking about the ways that Black women have had our labor and our production extracted from us, we also have to talk about the ways in which Black women are unfairly scrutinized, like Allison Felix feared, and policed in public and when we access personal healthcare services. This is a picture of the woman who came to be known as the welfare queen. Her name was Linda Taylor. She was one of the rare cases of welfare fraud that was then weaponized by then presidential hopeful Ronald Reagan from our home state of California, who used that as a caricature of all Black women and Black mothers in particular, to say that we should cut public services because Black motherhood is a grift. It's a way to try to steal public services and resources from the government by having more children, which was an incredibly hurtful, and it need not be said, but I will say, a complete lie of a characterization. But we also see that Black women are policed in other ways. A 2020 study led by Rachel Hardiman, an incredible Black woman scholar from University of Minnesota, found that high levels of neighborhood police exposure increases the risk of preterm birth for all women, all racial groups. But Since Black residents are more likely to be policed, they live in neighborhoods that have a higher incidence of police exposure, that their study was able to estimate that the gap in prenatal and preterm birth for Black women can be partially attributed to the racialized exposures to policing. We also know, and this is data from California Department of Public Health just last year, that Black women also report experiencing unfair treatment because of their race when they seek their prenatal and their hospitalized care. We know that Black women worry about being mistreated due to racism, and that worry has only increased from 2011 to 2019. As you can see, Black women are most worried about their loved ones, 60% who were surveyed in 2019, but 56% often worried for themselves in terms of being mistreated. And that they were mistreated. Black birthing people were more likely than others to have a cesarean delivery, which was not explained by clinical factors. And it's not just happening to Black women when they show up in our care as patients. It's also happening to Black providers. This is something that I'm also encountering in my work more recently to help with doula integration. Now that Medicaid is reimbursing doulas for their care, that when doulas come into the hospital, what we're hearing is that they're not respected, that they're being policed and scrutinized in the same way their patients are. This here is an example from JAMA in a perspectives piece that was written by a Black clinician, a physician, about what it feels like when she goes into her hospital. She said, "I watch the way no one makes space for me in the hall. I watch the way security guards try to hustle me along as if they perceive me to be in the way of a patient they are escorting. But the people I watch most closely when I'm invisible are other Black women in the hall. I observe that they do with their children what I do with mine. View them through the eyes of people who might judge their brown bodies, and pray that my children give onlookers no reason to judge." I think it's really important to acknowledge all the ways that Black caregivers show up along the perinatal equity continuum as both patients and as providers, and the ways in which they can be scrutinized and policed regardless of the role in which they show up. There was also a 2007 study, that found that Black race was independently associated with maternal or newborn testing for illicit drugs. This is again talking about Black birthing persons and the care they receive as patients. Black women and their newborns, as compared with non-Black women, were 1.5 times more likely to be tested for illicit drugs. Non-Hispanic Black children in foster care are less likely to be reunified with their parent in states that have adopted these punitive prenatal substance use policies than non-Hispanic white children who live in states that do not have those policies. So the impact of this over-scrutinization and policing of Black caregivers also affects their ability to be reunified with their own children. And this is a quote from an earlier work from 1994 by Dorothy Roberts. Dr. Roberts is probably one of the most preeminent minds in studying Black women's bodies and our treatment in medicine and in society. And this is something she wrote in the Connecticut Law Review about how Black women are seen and how our work is valued. She said, "The public views Black mothers as less fit, less caring, and less hurt by separation from their children. Contemporary poverty rhetoric blames Black single mothers. Dominant images have long depicted Black mothers as unfit. The ideal Black mother figure, Mammy, selflessly nurtured white children under her mistress's supervision. In contrast, whites portrayed Black slave mothers as careless and unable to properly care for their own children, even as they nurtured white children. The forced separation of Black mothers from their children began during slavery, when Black family members faced being auctioned off to different masters." This is an image from the Schomburg Center at the New York Public Library depicting one of those separations. Those separations continue today. During slavery, as few as 1/3 and as many as 2/3 of Black children were separated from their families. But as we know now, 1 in 2 Black children will experience a Child Protective Services investigation by the time they turn 18. 1 out of every 2. 50% of Black children and parents and caregivers are scrutinized for removal from their home. In Los Angeles County, the percentage of Black children experiencing a CPS investigation could be as high as 72%. And that was from a paper in American Journal of Public Health that came out in 2017. Again, from Dorothy Roberts in her book, Torn Apart, which is just a Bible about how we should abolish the child welfare system. She said, Black children are more likely than white children to be reported for maltreatment, to have allegations of their maltreatment investigated, and to be placed in foster care. Once taken from their homes, they and their families receive inferior services, Black children are shuffled to more placements and stay in foster care longer. They're less likely to ever return to their parents and more likely to have their parents' rights terminated, which, as Dr. Roberts notes, is one of the most devastating powers that the state has, which is to end families. And so, in the midst of all of these things that Black women, mothers, and caregivers are facing, the price to hold our head or keep our wits about us is high. And some of us struggle to do so. African American and Hispanic women more commonly reported postpartum depressive symptoms than white women. And similar factors like physical symptom burden, lack of social support, and lack of a feeling of self-efficacy were associated with early postpartum depression in women across racial groups. When we look here in California, this is again data from last year from the California Department of Health. 1 in 3 Black birthing people experienced clinically relevant symptoms of depression during their pregnancy or in the postpartum period. You can see Black women and birthing persons are here on the left, and that gray bar total experiences with depression is higher than any other group, as are, frankly, all the other bars. A 2011 study that analyzed administrative claims from nearly 30,000 Medicaid beneficiaries in New Jersey found that Black women were least likely to receive postpartum mental health care, follow-up treatment, and medication refills. Again, mental health conditions, as a reminder, is an important and treatable, completely preventable contributor to maternal mortality. This is data from the CDC from 2022 that shows that nearly, or a little bit over actually, 1 in 5 pregnancy-related deaths can be attributed to mental health conditions. This is more than cardiac and coronary conditions, which was about 12% as opposed to 22%. It's more than cardiomyopathy. It contributes more to pregnancy-related death than blood clots and hemorrhages and hypertensive disorders, the ones we tend to hear the most about. But that's not to ignore the impact of cardiovascular disease on maternal mortality. This is data here from the California Department of Health just last year again, where we see that Black women, which is the blue bars in each case, have higher rates of all of these major causes of pregnancy-related death and the highest rate of cardiovascular disease. Again, if we return to our Olympic champions, Allison Felix noted that she experienced complications in her delivery. These are the most preeminent athletes in all of our society, and she developed preeclampsia during pregnancy with her daughter Cameron, who was born in November 2018. She said the doctor sent her to the hospital where she would deliver Cameron in an emergency C-section at 32 weeks, which, for those who have experienced or witnessed that, you know how traumatic and scary those moments can be. She said, I was unsure if I was going to make it, if I was ever going to hold my precious daughter. And this, again, is the most decorated track and field athlete our country has ever seen, male or female. Tiana Madison Bartoletta, she is the 3rd person from the left, or if you're in the room, maybe the 3rd person from the right. She commented on her Instagram a couple years ago, 3 of the 4 of the members of this team who ran the 2nd fastest 4x1 of all time and were Olympic champions have nearly died or did die in childbirth. She said of her own experience, in fact, even though I went into labor at 26 weeks and went to the hospital with my medical directive and my will, I had a very tough conversation with my partner about who to save if it came down to it, and she wasn't confident she'd make it home. And then there's Tori Bowie. Tori Bowie was the fourth member of that team who was on the left, and she died in labor alone at 32 years old. According to NPR, her body was discovered during a welfare check after not being seen for several days. Who isn't checking on Black birthing persons for several days? The medical examiner cited possible complications from respiratory distress and eclampsia. So let's talk a bit about maternal death. According to the World Health Organization, maternal death is defined by the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and site of the pregnancy, from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. And the way we describe maternal mortality rates is as the number of maternal deaths per 100,000 live births. So we'll go through some of the data. First of all, we'll talk about maternal mortality. As I believe it was Dr. Williams in the room stated, for every pregnancy-related death, there are 70 severe maternal morbidity events or outcomes of labor and delivery that result in significant short or long-term consequences to someone's health. So for every death we go over, there are far more morbidity events that we need to understand, address, and prevent. But overall, not just for Black birthing persons, this country is a deadly place for anyone to deliver. This is data from the Commonwealth Fund that compares the United States to our other OECD peers. These are the other wealthy nations in the world. And you can see the United States, that light kind of turquoise green bar, far outpaces everybody else. And unfortunately, maternal mortality is rising here, even as it declines in other wealthy nations across the world. We can see that those rates have increased year after year. This is just data from the National Center for Health Statistics looking 2018 to 2021. Over the pandemic, we can see that that COVID exacerbated maternal mortality. So the dark purple bar are deaths related to COVID. The light purple bar are deaths not related to COVID. You can see that even not related to COVID between 2018 and 2021, maternal deaths still increased. And then COVID, especially in 2021, from the provisional data, added nearly half the same amount. So it almost doubled it. If we look by age group, we see that maternal mortality increases significantly with age and that birthing persons over age 40 are at highest risk. If we look by racial group, again, Black birthing persons have the highest maternal mortality. This is national data from the CDC as of March 2023, far outpacing other groups year over year. In 2021, the maternal mortality rate for Black women nationally was 2.6 times the rate for white women. But when we look only at national data, it obscures important regional variations. In New York City, Black mothers in some hospitals were 12 times more likely to die from pregnancy-related causes than white mothers, 12 times. Here in California, while the maternal mortality rate has been decreasing statewide, the enormous gap that exists between Black birthing persons and every other racial group has not narrowed, which is honestly a devastating indictment of how our systems have failed to protect us. Pregnancy-related mortality, as we went over, increases with age, but inequities in pregnancy-related mortality between Black women in California and those of other racial and ethnic groups are largest among those aged 35 years and older. So if you remember, when we looked at age, it's birthing persons over 40 that have the highest risk. But here in California, the mortality gap between racial groups is highest for those aged 35 and older, a younger cohort, where Black women are 4.6 times as likely as Californian women as a whole to die of pregnancy-related causes. Severe maternal morbidity has also increased. So again, remember, for every death we see, there are 70 more severe maternal morbidity events, and that has been increasing in our state over the last decade. Here, Black birthing persons are that bright blue line at the top, and white birthing persons are the gray line at the bottom. One potential buffer for maternal mortality rates nationwide is education. We see that maternal mortality rates can improve the more education we allow or foster girls and women to receive. However, unfortunately, educational attainment does not protect Black women from maternal mortality. You can see that Black women at every level of educational status continue to outpace every other racial group. Black women in this figure are the orange bars in terms of maternal mortality. This is, again, national data from the National Center for Health Statistics. Maternal deaths also vary by level of urbanization. This is data from the National Center for Health Statistics that shows rural counties, this high bar here on my left, have the highest rates of maternal mortality in 2021. These counties often have the highest rates of maternal mortality because they are maternity care deserts. A care desert is a place where there's no hospital that provides obstetric care, no birth centers, no OBGYN, and no certified nurse midwives, which in a rich country like the United States, it is an abomination that a place like this could even exist that literally has no maternity care. And yet, look at our country. Every red county there is a maternity care desert, and it's 2 out of every 3 rural counties. This is data from the March of Dimes in their Maternity Care Desert Report from 2022. They also found that counties with low access to telehealth were 30% more likely to be maternity care deserts, meaning folks there couldn't even phone a provider from another county to receive their maternity care. 1 in 4 Native American babies and 1 in 6 Black babies were born in areas with limited to no access to maternity care services in 2022. While rural areas face certain resource shortages that shape maternal mortality rates there, according to CDC data from 2022, urban areas continue to be places that experience high rates of maternal mortality. As they found among pregnancy-related deaths, with information on place of last residence, 82% of the descendants lived in an urban county. What happens when you live in urban counties often is that those counties are impacted by the historical legacy of segregation, economic and racial, that continues. And here in California, this is data from the California Department of Health, we see that Black birthing persons are most likely to live in neighborhoods that have less services, including healthcare services, because they are more segregated. Living in highly segregated communities generally increases the probability Black and Hispanic women will experience severe maternal morbidity, which again is much more common than maternal mortality. This is a paper from JAMA from 2022 that basically described how residential segregation was associated with severe maternal morbidity, even though they adjusted for patients' education, insurance status, obesity, nutrition, prenatal care access, and exposure to smoking during pregnancy. What the author said was that cumulative and mutually reinforcing discrimination, remember those colluding systems of domination, mutually reinforcing discrimination in housing, education, employment, criminal justice, economic opportunities, and healthcare is what places racial minority populations who live in segregated communities at higher risk of adverse maternal outcomes. But it's not just segregation by neighborhood that has devastating and deadly impacts on Black birthing persons. There's also segregation by hospital facilities that then shapes the quality of care that we receive. This is a paper from 2018 that showed that 75% of Black deliveries in the US occur in just a quarter of hospitals. Most Black folks are delivering in very few hospitals, whereas only 18% of whites delivered in those same hospitals. Further, they found hospitals that disproportionately care for Black deliveries had higher adjusted rates of severe maternal morbidity rates for both Black and white women in those hospitals. That means that hospitals that predominantly serve Black patients have poor outcomes for all delivering patients. In 2018, they estimated that if Black women delivered at the same hospitals as white women, nearly 1,000 Black women could avoid severe morbid events during their delivery hospitalization, which would reduce the severe maternal morbidity rate by about 30%. So there was a question earlier in the room about what initiatives work. One of the initiatives that works is ensuring that all women deliver at high quality hospitals. And when hospitals have bad outcomes, women should not be forced to deliver there, regardless of their insurance status. And even with the deaths that we see and the severe maternal morbidity that we see that happens during hospitalizations for delivery, the majority of pregnancy-related deaths actually happen after delivery, between day 7 and day 365, or 1 year postpartum. So the question then is, what supports await Black women, mothers, and birthing persons in the community so that they can enjoy physical, mental, emotional, and relational well-being? And who pays for those supports? Well, first, federal law now requires, thankfully, that pregnancy-related Medicaid coverage extend 60-day postpartum. And in 2021, that was extended to a full year. So if you look at a quick map from Kaiser Family Foundation, we see that our state, California, we are a part of the 38 states that have extended Medicaid postpartum for 12 full months. And if we look at how many people that's covering in California, the blue part of each of these pies is birthing persons who are covered, Black birthing persons who are covered by Medicaid. And what you can see is that before delivery, about 54% of Black birthing persons are covered by Medicaid, and after delivery, 62% are. So that extension of Medicaid for that year after is really important in reducing severe maternal mortality and morbidity. So just to review, what are the roots of maternal health inequities and what should be done to address them? So structural racism, structural racism, structural racism, right? We've gone over some of those examples around segregation, around policing and scrutinization, and the stress that Black birthing persons endure. And we just went over the data about lack of access to high quality, respectful care. This is data looking just at how those things live here in California from the California Department of Health. But looking nationally from our wonderful colleague, Joya Creer-Perry, who's also an OBGYN and a Black birthing person and mother, they've also identified this very powerful web of causation that thinks at the micro level about the historical structural drivers of inequity that continue to burden Black women's health. And I want to say a word about disembodiment. This again is from my article from The Nation. The result of all of these factors of how structural racism has shaped Black birthing persons' experience of their care is that Black birthing persons, women, and mothers have our personhood under siege. It's a forced abandonment and a stealing of our bodies as spaces for rest and realization, of that power that's derived from bodily autonomy and knowledge of self, and of the collective possibilities that could be availed us through democracy. And so generations of Black mothers have had their bodies, their power, and their possibilities stripped, whipped, cut, and chased from them. And when not snatched, then hidden. And when not hidden, then shamed away. And when not shamed, then legislated just beyond their grasp, like they recently are trying to do in Arizona with the new abortion law or ban. Even now, centuries removed from slavery, Black mothers might still be unable to disentangle ourselves from the conditions and forces and people that conspire to control us, our labor, our power, and our capacity for possibility. And yet, in the face of all this, because again, this is not a talk about Black maternal mortality, this is a talk about Black motherhood. I know a Black mother who laughed at the moment she delivered her baby without anesthesia. She laughed. I have a little timer. This means I need to speed it up so we have time for discussion. But I want us all to hold in our minds and our hearts right now the Black mothers and birthing persons you know. I know a generation of Black mothers who end their evenings sitting at kitchen tables with a slipper dangling over a crossed leg and silk robes cinched casually at the waist, filling the space between us with the warmth of their laughter. I know a generation of Black mothers whose chuckle rolls across their chest like the low, reassuring rumble of a washing machine, the kind of women who shape silence into a steady hum. I know women who crinkle, not crack, at the corner of their eyes and the edges of their cheeks, just enough that any fatigue that had settled there starts to fade as they rear their heads back and howl. I know Black women, mothers, and birthing persons who are our very best thing. My own grandmother was one of 23. Can you believe it? Her mother, my great-grandmother, birthed 23 children. It's a simple fact that could be read as the forced destiny of any woman whose reproductive choices are not her own. Yet it could also be read as the indefatigable effort of one Black woman to recreate the world in her own image 23 times over. The likely truth of the former distracts from the extraordinary probability of the latter. At its best, Black motherhood may be an attempt at world building. The best of Black motherhood entails the capacity to conjure new possibilities, not as products that come from our bodies, but as a function of simply being in ourselves. Being is a contested state for anyone whose personhood is challenged, denied, or relegated to a margin. So when Black women, birthing persons, and mothers dare to exist within bodies that fail to adhere to the norms of whiteness and femininity, not disassociated from them, we lay bare the cracks within systems of domination. We demonstrate that domination is never a totality. And once the cracks are uncovered, further cracking becomes possible. I think motherhood ripens Black women's temerity to generate the cracks that allow others to live embodied too. And so I think the real question before us is, how can we, as public health professionals and all of our partners, make space for, support, and stop blocking Black mothers, birthing persons, and women's embodiment? Embodiment requires attention to one's whole self, not our compartmentalized pieces or us as a statistic or number, but care for who we are as a person and a whole. And so when we think of embodiment and what it requires nourishing attention to oneself such that one is safe and supported as they inhabit our own body. And what Black women and birthing persons and mothers need to do that is time, space, knowledge, connection, protection, and love. And we're going to close by just talking about what all of that can look like. So what we need to be embodied is time. I think the Abundant Birth Project is one of the most radical and progressive Black maternal morbidity interventions in the nation. It provides guaranteed income to just under 2,000 individuals across California with monthly payments that last for a year to 18 months. It started in SF. It's spreading to 4 California counties. It's led by Black pediatrician and mother, Zaya Malawa. This is an incredibly powerful program. We talked about how Black women are breadwinners. We talked about how Black women have so much wage theft. Giving Black women money gives them time to do what they want. Freedom Community Clinic creates public space. This is an incredible clinic in Oakland, now with 2 sites in Oakland, that give Black women, mothers, and birthing persons and community members just public space, free from private scrutiny and public policing. It's designed and created for rest. Can you imagine a space where you're not even consuming anything? You're not paying for anything. You go there to chill, to relax, to receive healing touch. And Freedom Community Clinic honors those ancestral approaches to well-making. I invite everyone to check out their website. They're led by clinician Bernie Lim, who really is just a righteous young clinician who's blazing a path for herself and others. Knowledge, Black infant health, which I was and will be again a very gracious recipient of, is a powerful program that taught me a ton, even as a pediatrician myself, even as a doctor. It taught me so much about what was going to happen to me during my birthing process. And I'll get emotional if I start talking about how much that program helped me. So let's keep going. Connection. Doulas are an incredible service that now all insurances, it started with Medicaid, and just this past month, private insurances are now also reimbursing doulas for providing maternal care services. There are many Black-led doula organizations across the state. Frontline Doulas is based in LA, but they do statewide work to support doulas. We've been working with Roots of Labor Birth Collective, which is based in Alameda and San Francisco counties. Doula care is a beautiful way for Black birthing persons and for many of these organizations, queer and Indigenous Black birthing persons, to connect to our community and keep us in safe healing practices throughout our delivery process. Black birthing persons need protections. So we talked about the routine drug screening. And for those who have power, if this is happening in any facility that you're aware of, it has to be abolished. Routine urine collected at prenatal visits should never be utilized for drug screening without a mom's consent or informed refusal, meaning that you tell the parents enough about it that they can say no to it. This should be a hospital policy everywhere in the country and absolutely everywhere in here in California. And we need love. I started the article in The Nation by saying there's a boldness to Black pregnancy, an insolence to it. It smacks in the face of what society says we should be doing because it reveals the power that lives within us that we control. And so when we honor that power, when we give money to folks who have that power, when we give resources to folks who have that power, we as a society, as a state, and as a county are better for it. Addressing the deeply rooted causes of maternal health inequities will require multiple and sustained interventions at every level. That's already been said today. But there is hope. This is data from the CDC that shows that more than 80% of pregnancy-related deaths are completely preventable. There is so much we can do to support Black women, mothers, and birthing persons. And I am delighted to be a part of this community who is so focused on our needs and attentive to our care. So I want to stop here so we have time for questions. I ran a little bit over. I'm sorry about that. Let me stop share. Did that work?
Thank you so much, Dr. Boyd. I don't know if you could hear it, but we had some resounding table slaps and claps here for your words. Yes, yes. Okay, so we're gonna flip this and take some virtual questions first. For the audience members in person, do we have the index cards ready? And everyone has access to an index card? Wonderful. So while we're fielding the virtual spaces questions, please feel free to write any questions you have on your index card in front of you. And if possible, pass it closest to the center of the room on your table. Okay, actually, just raise your hand after you've written your question down, and one of our team members will receive it and bring it up here. Please also write legibly and big. Thank you. Okay, so your first question, Dr. Boyd, we have here. Thank you, Lisa, for this question. Do you think that women of African ancestry or women and mothers of African ancestry, that their perinatal health will decline even in California in a post-Dobbs America? And what do you recommend that we do to prevent national bans on abortion as relates to women's reproductive health nationwide?
I mean, start with the easy ones. Whoa. That is a very important and pretty tough question. I think in a post-Dobbs America, honestly, I think all of our health will decline. I think the health of women and girls is at the center of the health of society. As we already went over, women and women of color in particular are breadwinners in their homes. If we don't care for women, it is difficult for us to have thriving households. And not allowing women reproductive freedom and control over their own bodies will absolutely impede our ability to continue to provide for our households. So I think everyone's health actually will decline as a result of that. It's shameful and it's something that should be reversed. There are folks who are far better experts than I am on how that can be reversed. One recent argument I read that I thought was pretty powerful was that, we should have federal legislation to protect abortion just written into the Constitution. It shouldn't be an issue left up to, the whims of a non-elected court. It should be something that's in law for nearly half of our population to have bodily autonomy. So hopefully we can have a Congress that's brave enough to do the right thing.
Wonderful. Thank you so much. This next question comes from Dr. Amna Khan, who I would love to connect you to, Dr. Boyd, if you're not already connected. She's a pediatrician here in our system doing amazing things. And I posted her question in the chat that you're able to see, but I'll read it here too. Dr. Boyd, as a fellow pediatrician that learned in recent years that more than half of maternal morbidity and mortality occurs postpartum, I'm very disappointed that pediatricians have been left out of the larger conversation on how to provide more safety net protections for mother-baby dyads when they come into care, many times in the first few weeks post-birth at newborn visits. We are thinking deeply about this in our PEDS department. Do you know of any legislature or local clinics or programs that are in development to educate pediatricians more about this egregious health inequity so that we can best care for all mothers and newborns?
Gosh, thank you so much for that question, Dr. Khan. I don't know of programs that are educating pediatricians about this, but I do know that there was recent legislation during CalAIM to try to address it. So another thing that Medicaid now covers is like dyadic care and those dyadic care models. So, mama, birthing person, caregiver, and baby receiving care together for both their health care and their mental health care is now covered by Medicaid, which is new. That just happened in 2021. So because it's covered, I think an education campaign like you suggest is what will be really useful to make sure that the practice can actually be implemented and disseminated. I think clinicians need to know about it, like pediatricians. I think health plans need to know about it so that they can encourage hospitals and clinics to adopt the practice as well. I think dyadic care will be, if it's not already, like a best practice in pediatric care and in maternal infant care.
Another question from the virtual space. As a white male aspiring certified nurse midwife, how can we best support Black birthing people in our hands on care through the lifespan and, of course, through pregnancy and birth?
Good question. I think how you began that question was the start of it, like knowing the power that you occupy. So some of us have power because of the role we're in. Like as a clinician, I have power and there's a power dynamic and gap, asymmetry between me and my patients. As a white man, you occupy power, even if you're there just sweeping the floors. And so I think it's important that people understand the power they occupy when they come into space and that you cede that power to the patient. You give it to them, listen to them, let them decide how their care should proceed, allow them to have the support that they need in the room available with them. Don't belittle, and I say this from my own, honestly, training experience, like don't belittle the birthing plans and the desires of birthing people as they enter clinical spaces. I think we think when people come into our doors, like this is a clinical procedure and now we own you and it's going to go like this. And birthing is something humans have done for generations before the advent of modern medicine. It predates us, and there are traditions like doula care that predates medicine. And so listening to those and ancestral healers, I think is also really important for us. So seed power, I would say, is the best way to do it.
Absolutely. Thank you for that. And so this is our first question from the physical space. In areas with care deserts and poor quality of care, how can we ensure Black women get access to high quality care hospitals? How can we increase care at low quality hospitals, quote unquote, low quality hospitals to meet these needs?
So that's a bit of a systems question, which I think a lot of the structural, when we talk about like the structural racism, that level of racism lives at like an institution level. And there's a lot institutions can do to make sure that they're having high quality outcomes. Some of that happens at the government level. I heard there was somebody from the Board of Supervisors, like making sure if it's in your power to ensure that resources are disseminated evenly through our healthcare facilities, making sure there's parity between how much private payers and public payers like Medicaid can reimburse facilities for providing care so that the care you receive is equivalent regardless of the insurance type you have. Insurance is a major way that care gets segregated in our country. and Medicaid tends to pay less than other insurers. And so we need a redistribution of resources. And the folks who are gatekeepers over our resources tend to work either in the private sector or for the government. And so they should work together to make sure we all can have a shared resources when we go to sites. And then the last thing I'll say is if hospitals know they're a low quality site, if they know they have bad outcomes, I actually don't think they should get the privilege of caring for patients there, especially not if they're having poor maternal health outcomes. Like women shouldn't be the way that we just figure it out. Medicine has practiced on Black bodies for centuries, and that's got to stop. So that's why I presented that data about hospitalized care when 80% of Black birthing persons are delivering in low quality hospitals, they should immediately get to deliver in the high quality hospital. Like that intervention in and of itself, that study estimated would decrease maternal morbidity by 30%, which is huge.
Absolutely. Thank you for that. We're going to take one more question before our break. And this one is from Sudi. With a population of incarcerated women being overwhelmingly Black and brown, are there audits of actual programs in place? And then a note that the policies are only as good as reliable audits beyond review handbooks.
I actually don't know much about the auditing process for like incarcerated facilities, but I will say that there are some services, the Roots of Birth Labor Collective that I talked about doing some work with, they actually provide doula services at Santa Rita County Jail. That was an initiative that took years in the making and had to find a source of funding and had to get contracting from the county. They did it for free, for years, for free. I think that's something we didn't say. Most doulas actually suffer from a volunteerism problem. Like Black birthing persons and the doulas who care for them have been doing this work for free because folks haven't had the ability to pay for it. And so I think ways of supporting services like that, paying for it through public funds and spreading them to more facilities so that even when people leave the community and when they return, they can receive continuity in their doula care and in their prenatal care is really important.
Thank you. And yeah, thank you for that shout out. Yeah, Roots of Labor Birth Collective doing amazing work at Santa Rita. So that concludes. I'm just going to read this. It's not a question, but a statement. Thank you, Dr. Boyd, for an extremely well-organized presentation. It was perfect.
Thank you so much. Thank you for everyone who put these little hearts in the chat. I also want to thank Odiri, who I think was in the room. Odiri is who connected me to Black Infant Health, which literally, like I said, we can't even get into how much Black Infant Health has helped me. So thank you to all of y'all and all the work you're doing.